We are now going to talk about volume. All right, so when we're talking about volume, we mean, does your patient have enough volume or does your patient not have enough volume? Does your patient need volume? Has your patient received enough volume? Does your patient need inotropes? Does your patient not need inotropes? It's a big question to ask, because the problem is that if you start inotropes too quickly, there's nothing wrong with it, but your patient may not have needed it in the first place, all right? And if you delay inotropes for too long and keep on giving your patient fluid, you're just going to push them into an edematous state, which is even just as detrimental. So that's why, I'm sorry I'm speaking this way. I'm trying to speak at the speaker and you all at this. So that's the reason that we need to know about this. Now, we're not talking about shock, all right? We're talking purely about trauma, which we've been talking about all these weeks. The EFAS, the whole exam, this is a trauma patient. In a few weeks, we're going to get to something called the RUSH protocol, which is how we assess shock in using an ultrasound. That's completely different because we look at medical causes and things like that. This is what we are talking about is purely in terms of trauma. So you've got your trauma patient in front of you. You've checked the liver, suprapubic, you've done the splenic view, you've checked for pneumothorax, hemothorax, you've looked at the cardiac view. Now you're coming to check, does my patient need fluids? All right, because your patient's BP may be low, patient may be tachycardic, there may be quite a few things that are going on. So, let's have a look at that and see, all right? So that's what we're going to concentrate on. Let me just get up my pointer and then we'll go from there. All right, and if I lose anybody, just tell me. Just want to see there's nobody waiting to get in. All right, no problem. Okay, so this is what we are looking at. Does my patient need fluid? Does my patient need large or small amounts of fluid? That's the other thing it helps us to decide. After I've given my fluids, is my patient responding? In other words, to monitor the response to those fluids. We have to make sure we don't overload our patient with fluid. And then does my patient need inotropic support, vasopressor support, things like that, all right? So we are starting off from the point of view that we have a polytrauma patient is in shock. We have seen free fluid in the abdomen or even the chest. Okay, so that's where we're starting off from, okay? So ultrasound comes in really handy. So what do you think we would use to monitor volume? Just a question, what would you use? I mean, let's say you didn't have an ultrasound. What would you use to check your patient's volume response? Very good, BP. So what determines the BP? Where does your BP come from? What creates blood pressure? Yeah, very good, it's the heart. Okay, so that should be your first clue. So that means you can look physically at the heart as well and see how it's doing. And number two, when you put your BP cuff on, what are you checking? You're checking how quickly your arteries collapse and how quickly they reinflate. So we're using those two aspects. We're just changing them around a little bit so that we can actually look at the BP in physical time. Okay, right. So let's look at our left ventricle over here. Okay. So the first thing that we look at is our left ventricle. You can look at the subxiphoid view. You can look at the parasternal long view. Which one is this that we're looking at now? This is subxiphoid view, all right? The reason why we say that, there's a liver over there. That's our right ventricle, left ventricle, right atrium, left atrium, all right? I'm gonna keep on teaching you guys that until you know it, okay? So we're not just looking at rate, but we're trying to look at whether the ventricle is hyperdynamic or not, all right? So what we're seeing on this side is a left ventricle that's normal, agreed? It's pumping away, the walls are not touching one another, it's going at a regular rate, that's quite normal, okay? Now, let's take let's look at another one, all right? Oh, well, this is now just the parasternal long view, all right? So in this case as well, we see a left ventricle that's got a nice rate, its walls are moving nicely, the heart is moving at generally easy pace, all right? So those are the two things to note. The heart rate is not excessive and the ventricular walls do not touch each other when contracting. Okay, so this is just the parasternal long. So with parasternal long, we see right ventricle, left atrium, mitral valve, aortic valve, and the root of the aorta, and the descending aorta. Okay, so you remember that. Okay, very good. Don't worry, next week, like I said, there's a better projector coming. It will look nicer. I know it doesn't look too. And if you can't see it, please come and have a look at it on the screen. Okay. Right. This one here is audio. I hope it will play. Right. So let's have a look at this ventricle now. All right. I was hoping it would still look right there. Sorry about this one. So let's have a look. So this is a subxiphoid view again. All right. So it's looking at that. So here we have the right ventricle, right atrium, left atrium, and left ventricle. So can you see the difference this time? What's happening to that left ventricle specifically on this side? Good, very good. The walls are collapsing. And what about the rate? It's faster. The reason being, there's not enough fluid in the system. So how does a ventricle compensate? It pumps faster and it pumps harder. Remember, your body is always trying to keep homeostasis. Okay, so by whatever means necessary. Okay, so it's pumping out as fast as it can. Right. Let's stop this one for a second and let's just concentrate on the other one. Sorry about that. Right. Let's pause that. Let's look at the parasternal long view. Let's say for some reason you can't get the subxiphoid view. Let's have a look at the parasternal long view. So what do you notice about this left ventricle as well? Can you see? All right, so that's right ventricle, left atrium, left ventricle. Right? There are some disease aspects to this ventricle, but what's the most important thing that we know? Number one, the rate. It's excessive, isn't it? It's moving quite high. And the walls touching one another. All right. So ejection fraction, we've all seen ejection fraction on echo reports, basically refers to how much that ventricle is contracting. So when you've got a patient with an ejection fraction of 20%, it means it's doing that. It's closing less than 20%, whereas this is 100%. A ventricle that's not moving is 0%. Got it? So we've got a ventricle here that's busy going at nearly 100% to try and get as much fluid, blood, all right, as much blood out into the system as possible so that it can keep the blood pressure up. Okay, so that's the first thing that we looked at, which is the pump, right? Now, the next thing that we look at is the inferior vena cava. And the reason why we look at the inferior vena cava is because the inferior vena cava tells us about the tank. Now, we're busy pumping with the pump. The question is what's happening down there in the pipes, sorry, not the tank, in the pipes. It's no use having a pump that's working, but your hose pipe is not working properly or your hose pipe is not getting pressure. So that's essentially what the IVC is. So if we remember correctly, in the abdomen, you've got a aorta, you've got your IVC, and this is how you place your probe. So you place your probe just that way with the indicator towards this side, right, towards the patient's right. And this is what we'll see. So the first thing that we see is we see the vertebral body, all right? So you guys would remember that bone basically absorbs all the ultrasound waves. So you don't see anything behind the vertebra. So that's why we've got this empty space, all right? And on top of that, you've got the aorta, which is pulsatile, okay? And then you've got the inferior vena cava, that's on this side, okay? So let's say we do have a patient who doesn't have enough fluid in their body. What do you think the inferior vena cava will look like? Nice and fat or nice and small? What about a patient who's got enough fluid? See, medicine is simple. It's not difficult. We make it difficult. All right. So let's have a look at some examples of that. Okay. Right. Oh, why does it look like that? Sorry about that. So let's have a look at the eye. So what happens is we put our probe on there. All right. We locate the IVC so we can see where it is. Let me just go back one. I'm sorry, I'm not sure why it's projecting that. So we see this view when we're in a transverse view. So we know where the IVC is. We center the probe over the IVC and then we turn it 90 degrees. So that now the indicator is facing towards the head. So what will happen is instead of seeing the IVC in cross section, we see the IVC in long view, all right, in a longitudinal axis. So that's what we're supposed to be seeing on this side. I have no idea why it looks like this, but we can still see the IVC over there, all right? So this is the IVC, non-pulsatile. And just up here, we're supposed to be able to see the right ventricle. Like I said, I have no idea why it looks like this, all right? Now what we do is we watch the IVC on each breath. The reason being, when we breathe in, how do we breathe in? Our diaphragm goes down. Our diaphragm creates negative pressure so that we can draw in air. And then by the same time, it draws blood up from the IVC. Okay. So the more that this collapses, the less fluid we have in our system, the less blood that we have in our system. So when we breathe in, there's not that much fluid in the first place. So it all gets sucked up. So the IVC closes down. Right? We breathe out, kind of expands again. We breathe in again, everything gets drawn out. So the whole pipe collapses again. All right. So this is a normal one. This is what it's supposed to look like. Okay. Every time you breathe, it collapses a little bit, but there's still sufficient fluid. If we don't have enough, then we'll see. All right. So the more it collapses, the more hypovolemic our patient is, which I'll show you now in a minute. All right. Conversely, the less it collapses, all right, the closer our patient is to overload. All right, we're about to push our patient into what you call it, pulmonary edema. This is just a relatively normal IVC and what it should look like. I hope some of the others look better. I'm sorry, I checked this before. I have no idea why it's projecting like that. Oh, so this is the normal one, all right? Now let's look at a hypovolemic one. So look at what happens. Every time the patient takes a breath, what happens? Collapses. Actually looks like it's about to give a kiss. Agreed. All right. Because what's happening is that it's actually pulling out all of that fluid every time the patient breathes. Whatever fluid is there is gone. So that means if we see a patient like this, is it safe for us to give fluids? Yes. Our patient needs fluid, whatever it may be it what you call it, crystalloid, colloid, blood, FDP, whatever you're giving that patient, but you need to give this patient something because this patient is in need of fluid. This patient doesn't need inotropes, doesn't need anything. This patient basically needs to be given fluid as much as possible. So what will happen is you will start giving your patient fluids. Now you want to monitor the response. How are you going to monitor the response? By looking at this again. So let's say you've given your patient a liter and it starts looking more like this. Now you know your patient's getting back towards normal. You've given your patient a liter and it's still collapsing quite a bit. Maybe not as much as before, but it's still collapsing. You know it's safe for me to give another liter, all right? So that's basically how we do it, all right? Sorry about this one, all right? So let's compare it now to fluid overload, all right? So let's say we've given our patient, oh, this is what we see when we start off. What's happening to this IVC with each breath? Nothing. It's just sitting there. The pipe is full. It's absolutely full. So giving fluids is not going to do anything. Your pipe is already full. So if you give fluids now in a pipe that's full, all that's going to happen is that fluid is going to leak out. And where is it going to leak out? Lungs. Besides everywhere else, but I mean, we worry more about the lungs. The reason being, we're going to push our patient into pulmonary edema. Okay. Now, on the other hand, you have a patient like this. You've given them fluids. Their BP is still sitting at about 70/30. What does that mean? It means the problem is not fluids. The problem is coming from the pump. That means the heart itself is unable to push out whatever fluid you are giving it. So how do you get a heart to pump? Inotropes. Okay, in this case, vasopressors are not going to work. All right, vasopressors, remember, shut down all of or they increase your vascular resistance peripherally. So basically, if you had to give this patient vasopressors, you're going to be pushing more fluid into a system that's already overloaded. All right. So that's another way, because in some institutions when you work, there's always this debate about pressors versus inotropes, what you should start with. So these are tools that you can use to help you decide which one. All right. So this patient here is actually very close to being completely fluid overloaded, right? As you can see. So if this patient still has low BPs, this patient needs inotropes. Now, a lot of our CCF patients present like this, all right, as well. So if you have a CCF patient, try and put the probe on them. You'll actually see that that's what the IVC looks like. Okay, now please don't start them on inotropes. Okay, our CCF patients don't need inotropes. They need actually to reduce their afterload. They need milnirone, things like that, right? But just as something to try, okay? And then any patient who's got a low BP, put it on them. See, do I need to give this patient fluids? Is this patient responding to my fluids? Because that's really what I need to know, okay? All right, let's go to another one. So this is just a video to show us how it's done, okay? Sorry.
Here is it's just taking a 30 linear 3 to 5 megahertz probe. He's aiming the indicator towards the head. He's placing it just under the xiphoid process, and then he's just sliding 1 to 2 centimeters to the patient's right. So that's the deal. Probe goes just under the xiphoid. Slide 1 to 2 centimeters to the patient's right, and you just tilt towards the heart. So let's go through the normal anatomy you'll then see on your ultrasound screen. So what you see is you see a IVC, black thin-walled structure underneath the liver, and you're getting just a cut of the heart, the right atrium. And that's key. That's the proper position. You have just a little bit of the heart there. All right. And you see that arrow? That's measuring 1 centimeter past the hepatic vein towards the patient's feet. That's where you want to look at the IVC. If you can't see that, then you just go about 2 to 3 centimeters from the heart border. So just to review that anatomy one more time, that thin black vascular structure is the IVC, liver's on top of it, and you're getting just a tiny cut of the heart. About 1 centimeter past the hepatic vein, or 2 to 3 centimeters from the heart edge, is where you look at the IVC. This IVC is collapsing nearly completely, but anything greater than 50% is a patient who's going to be responsive to fluid. So that's the most validating number. If the IVC collapses more than 50%, give them some fluid. I would tell you if it's greater than 30%, which is really what you can easily see with your eye, I would probably, in most cases, give them fluid. So if you're really seeing any significant collapse, then the patient needs fluid. All right, give that patient 4 liters of fluid. Look at the IVC now. No respiratory collapse. If we look just past the hepatic vein, that IVC is not collapsing with respiration. It's staying pretty much identically sized throughout the respiration cycle. This patient doesn't need fluid. All right, another patient who has near complete or certainly greater than 50% collapse of their IVC with respiration. Patient needs fluid. All right, we gave that patient 2 liters. We take a look at the IVC again. It's bigger, but it's still collapsing greater than 50%. More fluid needed. Here's another patient that needs fluid. IVC collapsing just past that hepatic vein with respiration. All right, we gave that patient 6 liters of fluid. Look at the IVC now. No respiratory collapse. Staying just about the same size. All right, just one key point to understand about all this. Fluid unresponsive does not mean fluid loaded. All right, it just means the patient is not going to increase their cardiac output with fluid. That's what the collapsing of the IVC tells you. Sometimes you have a patient with negative inotropy secondary to their septic state who will not be fluid responsive, and their IVC will not collapse. But then you give them some inotropy with some calcium or dobutamine, all of a sudden their heart's pumping better. If you look at their IVC again, it will start collapsing, and that patient then needs more fluid.
And something to go back and watch, you know. But it doesn't matter how many of these videos or how many of these presentations you have. If you don't physically do it on patients, you will never know it when the time comes. So the best thing to do is practice on patients who are stable, but who have signs of this. So when the polytrauma patient comes in, like how we did with ours, we practice our E-fast on a person who wasn't dying, you know. So, so when the patient is dying, then you know how to do the E-fast. Okay, all right. Let's just see what else. All right. So now you consider adrenaline if there's no response. All right. Basically, what they're talking about, inotropy. So in other words, you've given your patient as much fluid as they are going to handle. They're not picking up their BPs. They're not improving. This is the point at which you consider adrenaline. All right. So just so that you guys know, standard single strength adrenaline is 4 amps or 4 milligrams in 200 mils of crystalloid run at 10 mils per hour. That's standard. So in other words, if you tell somebody that you're starting them on an adrenaline infusion, this is what you mean. They will understand. If you say I'm starting them on single strength adrenaline. Now, of course, you can adjust this upwards or downwards depending on your patient's response. Okay. If you tell somebody I'm putting, you know, oh yeah, so there's weight-based charts. There's lots of ways that you can give adrenaline. Okay. So it's really up to you if you choose to use one of the other methods. It's just that single strength and double strength are kind of well understood. You know, you don't have to explain what you are doing when you tell somebody you're giving single strength adrenaline. And by the same token, if you tell them you're giving double strength adrenaline, which is 8 amps instead of 4 amps, they will immediately understand what you are talking about. Okay. And you go higher than that too, but generally in ICU, all right? Triple strength, they've used once or twice yet, but it's like last resort, your patient, you're just giving them their last chance. So if your patient is not responding to single strength, you can try double strength, but most of the time in the A&E single strength, we adjust until we get the patient up to a particular level. If you feel you need double strength, you ask for senior help, and then we take it further from there, all right? So that you guys know how to do it, all right? That's the thing. So the other thing I just wanted to mention before we finish off, any fluid that you are giving, you must make sure that fluid's not coming out anywhere. When I say that, what I mean is it's no use pouring water into an empty bucket, agreed? Or into a bucket with a big hole in it, all right? So if you've got a patient who's actively bleeding and the BPs are low, you can give them as much fluid as you need. That's still going to be coming out. So these are all the things that you have to consider as well, right? So if the patient's actively bleeding, actively having some sort of fluid loss, that patient needs to be taken to theater. Agreed. You're not going to sit with them for 4 hours, try and get their fluid levels up, because literally it's like pouring water into a bucket with a hole in. Everything just keeps coming out. No matter how hard you try, you never get it out. All right. So yeah, that was basically that. I don't know if you guys have any questions. I know I go a bit fast sometimes. Today I am in a bit of a rush, I'm sorry. But need to get back to the wife and the kid. But I just want to know if you have any questions or anything that you would like to know, or anything that's still confusing. Even on Zoom, if you guys have any questions or anything you want to know, now's the time. And you can ask over the speaker as well. You don't have to do it over chat. All right. So this is not an uncommon situation. I mean, we face people with low BPs. How many times a day? Majority of our patients have got low BPs, agreed. So it's very easy to check. So you've got, even for example, your CCF patient who comes in. You're not sure if this BP is because this patient just looks puffy or if this genuine CCF. Now, there's lots of ways to check CCF. Put the probe on, look at that IVC and see. I've got a big IVC. I know I don't need to put up a liter of fluid, all right? I've got this patient who looks very fluid overloaded, but actually their IVC is collapsing all the time. Let's see if they are responding. We've got young man comes in, decided 2 years ago, he's not going to take his RVD treatment. You can see his maxilla through there. I mean, his cheekbones, you can see everything, and his BPs are low. Agreed. Put the probe on, see how much of fluid he needs to try and get him up. There's absolutely, yeah. Oh, very good. Nkadi, you're 100% right. You have the IVC collapsibility index percentage, all right, which I am going to put up over here as well, all right? Now, the reason why I didn't want to mention it here is I felt people would feel a bit overwhelmed by formulas, but I'm going to type it out for you, all right? So it's the Dmax, all right, minus the Dm. So in other words, the maximum diameter minus the minimum diameter divided by the maximum diameter again, all right? So you get that whole is equal to a number, all right? Let's call that number y, and you multiply that by 100. Okay, so that's the collapsibility index, all right? That's how you work it out. Then what they say is that if you have less than 25, all right, so if that number that you get is less than 25, your patient is now, let's say, fluid let's just say fluid loaded, not fluid overloaded, all right? And if you get greater than 75, so the number comes out to greater 75, the patient needs fluids, all right? The problem with this is that it doesn't look at your patient, and it doesn't specifically look at everything. And you need motion mode, what's called M mode on your ultrasound. And you need to know how to use that properly, all right? So if you don't know how to use M mode on the IVC, it's a bit difficult, right? And it has to be measured according to every respiration and things like that. So my hope was that first, when you guys get the hang of actually doing the IVC and looking at it, then I was going to show you how to do the IVC compression ratio, which gives you an exact percentage. So you know exactly how far your patient is going. However, it's a bit more in detail on the machine as well. So I hope you don't mind, Adi, that I'm just skipping it out today a little bit. It's not because it doesn't exist. It's just, it's a bit more intricate. Okay. All right. Any other questions? Anything anybody else wants to know? Are you happy? You don't look sad. Everybody looks sad and worried, like, you know, it's not that much to learn, trust me, all right? It's easy once you get the hang of it, but the only way that you get the hang of it is to actually practice on patients, you know, practice on patients, and you'll see how easy it will become after a little while, okay? But Mkari, thanks, that was an excellent question actually, but I hope you understand why I skipped over it this time, okay? Because if you guys don't know how to just look at the initial ventricular collapse, IVC collapse, then it's very difficult to understand how the IVC collapsibility index is supposed to be used as well. It tends to become a bit too technical after that, because a lot of the time in a polytrauma patient, you don't have time to take out your calculator. You've just got to be able to sit and work out just by eyeballing. All right. Okay. So I hope that's understandable. I hope that makes sense. I know you're half asleep from last night. I apologize. Okay. Sure. No other questions? All right. Anybody on Zoom? Any more questions? Okay. So we'll end the meeting over there. Thank you, everybody. The next one will be on Friday. It will be purely via Zoom on Friday. Okay. All right. Keep well, everybody. Bye.